Okay, now I think I'll handle the session.
So I think that I am going to interrupt here, not take more questions because we have flights and timings to make. So I would request Vani and Arti to join combined and to have a discussion on behavioral aspects of obesity. So Vani, over to you.
So I'll just
You can join her, Arti.
can join, but we have prepared separate presentations, so it's not practically implementable. What I will do is, I had foreseen this a little weight and there seems to be some issue they are not able to. So this is really not a real life experience that I'm trying to share. Next slide please. So the scope of my presentation is not to make you all psychiatrists. It's only that you can have some tools to assess the mental health, to classify and what are the thresholds for reference. So very limited goal of this presentation, just these 3 points. So what is mental illness? That's the commonest question that people ask me. So mental illness, most frequently the patients who come to me tell me that most of the other doctors have told them nothing is wrong with you. Don't worry, you're absolutely okay. There is nothing wrong with you. That's not true. Mental illness is a legitimate medical condition. What are the features of it? It manifests as disturbed emotions, thoughts and behaviors as primary symptoms. They may not be the exclusive symptoms. There are always other symptoms, always accompanied by disturbed biological functions such as disturbed sleep, appetite, sexual dysfunction, body feeling. And diagnosis is empirical. For example, the common question that anti-psychiatry people ask us is, what is the test? Do a blood test or a scan and tell us that we have mental illness. We don't need a scan to tell us what the patient can already tell us. Hath Kangan ko RCQ. If the patient says I am depressed, why should I do a medical scan? Patients are not here to play some joke on me and tell me lies. So it is, but still diagnosis is essentially empirical. All mental illnesses are considered as syndromes. So there is a recognizable cluster of signs, symptoms, course, onset and natural outcomes. Most importantly, if you cannot find anything wrong with the patient, don't assume that he has a mental illness. It means that you have not found something which may not be a mental illness. Pardon? So most of the times, so I remember when I was a student in Pune, we had a GVC OPD, General Weight Complaint OPD, and everybody, it used to be managed unfortunately largely by psychiatrists. Psychiatry is not general weight complaints. So that is the scope of mental illness. So it is a legitimate medical condition. We have to understand that. What is the significance? Most of the times, mental illness is considered as some kind of a sideshow, and many times, even psychiatrists tell people, treat the mental illness to improve the quality of life, as if that is a luxury. You know, who has a quality of life? Instead of lying down on a chatai, you make the person lie on a Kurlon mattress. That is not mental illness. Mental illness is absolutely essential, baseline and much more important than anything else. We want to treat the patient completely so that he returns to a complete state of health. Mental illness also has a bidirectional association with every other health condition. Whether it's a skin condition, whether it's a kidney condition, whether it's a hematological condition, mental illness will increase and that condition will decrease the mental health. It determines patient health behavior at every level. Mental illness can contribute to illness, it can add to the progress of the illness, it can interfere with their treatment, and it can affect your recovery, including by affecting the patient's perception of what is recovery. Also, what we just discussed in Arti's presentation, advanced knowledge helps healthcare provider treat most challenging cases with ease. So the most common tea break or lunch break presentation is, how do you treat this patient like this? How do you get the fees? How do you ensure? So what happens is, when you, each of us as practitioners implicitly gain mental health knowledge. Each of us have certain patterns, who are difficult patients, who are easy patients. And every profession has senior practitioners who are more adept at managing difficult people, and that is because they acquire this kind of mental health knowledge, which may not be a formal mental health knowledge, it's a simple social mental health knowledge. And instead of getting upset with patient behaviors, fees not paid, they are able to deal with the mental health circumstances and focus on the problem at hand, which is the complexity of the illness. And that is why, whether you are a nephrologist or an endocrinologist, being able to treat the mental health question in your patient helps you to get it out of the way so that you can focus on your specialty. So if you get caught up in indulging the patient because he's a VIP, or get caught up in negotiating the patient because he doesn't want to pay you, then your time gets wasted in that kind of negotiation rather than treating whatever is your main thing. So advanced knowledge of mental health helps the healthcare provider treat most challenging cases with ease. So there's a very simple scheme for assessment which can be applicable in any clinic. It consists of 3 parts. What you need to know from the patient is what is the mental status examination, what is the patient's explanatory model of the illness, and what is the mental or behavioral dysfunction that the patient has. These 3 things will give you an idea of what's happening. So mental status examination, this is my own definition. It's a systematic evaluation of the internal mental experience of the patient in a defined period. Usually you want to define it within the last 1 week. And the components are general appearance and behavior. Again, this, you can read any standard textbook of psychiatry and get a formal definition, what to look and when. But every one of us, when during our training period, we get an idea, So for example, sir showed us examples of how the Cushing's disease patient looks like, how the hypothyroid patient looks like. Similarly, in mental health, what is important is what kind of grooming and dress the patient has. Is the patient showing any kind of abnormal actions or facial features? Is the patient looking somewhat different, upset, angry, all those kinds of things. Speech, again, any unusual features. Patient is talking too much. One of the examples they say a patient is phoning you again and again, asking the same question again and again. That's unusual. Now about thought, mood and perception. You have to ask the patient, what do you think about? What kind of thoughts do you get? And we know what are the morbid thoughts because we have a basic medical training. Are the thoughts negative? Are the thoughts unusual? Is there any kind of preoccupation? And because we are talking about obesity, we want to know whether there are any body image disturbances or any fixations about weight. What should be the weight? What is abnormal weight, normal weight? Again, mood. Most concerned we are about whether the patient feels depressed and is this mood experienced most of the time. Perceptions, again, mostly we think about delusions and hallucinations. But in the case of obesity, what we more want to ask is what are the bodily perceptions like heaviness, slowness, and these kind of perceptions. Now, all these findings are interpreted in the context of patients' higher mental functions and socio-cultural backgrounds. So, if you have an elderly patient whose cognitive functions are not quite okay, then you have to understand why he is maybe not well-dressed or not well-groomed. And if the patient comes from a very rustic kind of background, a lot of patients who come to us and we say that, look, your weight is appearing a little more than the normal. The person from the rustic background says, that's not my weight, that's a lot of water that is filled in me, which is a common belief that is held in the villages. So these things have to be, so immediately it doesn't need a psychiatry referral that, okay, this person believes there's water in the body. So these have to be interpreted like this. Now, what is the insight and explanatory model? In your second consultation, you'll seek to find out if the patient actually understands that this is an illness. For example, in an earlier presentation, I had showed that obesity was a very sought after value. In the olden days, somebody who was obese like the kings of England or some chiefs of some tribes, they were thought to be they thought to be signifying power, the ability to get more resources, the ability to be healthy, powerful, handsome. Those fat people were supposed to be looking very sexy. So, in such context, they may not consider this as being a morbid thing. So, it depends upon that. What about the measures taken? What is their understanding? So what needs to be done? For example, if there is a person who believes that increased weight and the shape of the body is due to excessive water, then they would try to do water restriction. That is in keeping with their explanatory model. Then what is the understanding of state of health or disease in the patient's culture or in the family? What do they believe is a disease and what do they believe as a health? Unless you understand that, you will not be able to educate the patient what is your model. What is the cause of illness? For example, a few minutes ago, Dr. Anish told us that during pregnancy, women are supposed to eat for themselves and the baby. And if they look nice and round, then everybody is satisfied that this is going to have a good outcome in the pregnancy. So, increased eating is not considered as a contributing factor to obesity. They may consider that probably because of the cesarean section there is an obesity, So there is an attributional bias. Understanding of remedies and treatment, again, as I had said earlier, all this is in the context of the personality and culture. What is the patient's therapeutic goal? What is your therapeutic goal? Your therapeutic goal is to reduce the metabolic risk. Patient's therapeutic goal may be to fit in a particular size of clothing. Understand the starting and end point of treatment, because patient may feel it is still not time to start treatment, whereas you feel that you want to do early treatment so that the complications are less and the outcome is more beneficial. Mode of respectful communication. That's the other thing which Dr. Arti covered very nicely. If you understand the patient's culture, the background from which the patient comes. For example, now I have joined a clinic where a certain kind of patient comes and they repeatedly ask to hug me as a form of showing that, oh, I care about them, or whenever they want to thank me, they want to hug me. So that kind of thing you have to understand, and it is also your culture that is important. Just because you are a service provider and the patient wants to hug you, you are not going to go and hug. So there has to be a common place where these two cultures meet so that the consultation appears respectful both to the patient and to yourself. And the mode and meaning of transactions. So for example, I used to work during my internship, I used to work in a village. Obviously, we were not supposed to accept any money from the patients. But sometimes when I treated their infections very well or spoke very nicely to them, they would come back with a bag of vegetables. And because I had read that we should not take anything, I used to turn them away. So a few days later, my senior explained to me that this is a cultural exchange and they feel rejected if you don't take these gifts. So try to take 1 or 2 potatoes or tomatoes what they are giving. Don't take too much so that you give them respect as well as you keep your value system with you. So mode and meaning of transactions, and that is why most of the patients ask us, why are you charging us so much for only talking? It's not that the patient is trying to minimize what we do or trivialize what we do. It is just that the patient's understanding of what a treatment should be like, what they expected from you. So it is more an opportunity to educate the patient that when you come to a psychiatrist, this is what is to be expected, and that is why we are charging for this. Now, knowing what is the amount of disability and dysfunction due to the patient's emotion and behavior helps us to decide whether it is really warranting a referral. One is comprehension. Whatever instructions you are giving to the patient, is the patient able to understand? For example, what we see that in an average prescription, there are a very large number of medications with very complex kind of dosing. Sometimes the patient may be from a background, he may not be too educated, We may write in English, patient may not be very conversant in English, patient may go back home, there may be multiple relatives in the house. There's a lot of confusion how the medication is to be taken. Plus, patient's own culture, there could be certain things like medicine has to be taken before food, after food, with water, with hot water, milk. There are so many things. So we have to see whether the patient is able to comprehend. And when mental health conditions exist, then the comprehension of the patient is impaired. So a lot of times we feel patient is not following our instructions, whereas the patient is trying their best, but it is beyond their capacity to understand that. Therefore, the compliance also goes down. The quality of consultation. Patient may appear too much needy because they are anxious. Patient may appear very aggressive or very provocative because they are irritable. Or patient may appear patient may be confused, so they appear very indifferent to whatever. So you feel that you are trying to engage in the patient, educate the patient, but patient is not responding to you. So the quality of the consultation goes down and you also lose interest in the patient. Many times we feel that why should I bother so much when the patient is not bothered. So the quality, but the real problem is that the mental health issue is the one which is creating the problem. Similarly, the lack of expected response for a consultation as well as for the treatment. Adverse and unwanted outcomes. You're giving a certain treatment, but the patient comes up and reports that some other outcome has happened, and sometimes even medical legal outcomes can occur. One of the interesting examples shared by my colleague was that a patient went and reported to the police that she was being sexually assaulted by a psychiatrist, and when they actually went to the police station, the lady said that he's entering me to the bindi. Immediately the police came to know that the patient is not thinking right. And so there may be a lot of misunderstanding because of the thought disorder. Now this is a very gross case I told you, but these kind of misunderstandings can also lead to medical legal disputes. Very simple classification which I have made. It's a very easy and utilitarian classification. Patients based on these three findings can be classified as high probability to require referral, that is you have to refer immediately to a mental health professional. Moderate probability, where you have to observe closely and encourage. He doesn't have to go immediately like today, can go over a period of time. And a low probability is monitor as usual, probably in the long term they don't need a referral. So who are they? High probability means those who absolutely require a referral are patients who have had any diagnosis of mental health condition previously. If they are not with a psychiatrist in the last 6 months, you tell them have one review and come back. It may not be there, but have a review and come back. Patients who are taking psychotropic medication, including Trica, Restil, please get a review. Ask a mental health professional, come back. Patients with grossly abnormal behavior, please encourage early consultation. Patients expressing suicidal thoughts, either in the past or now. I'm so fed up of my diabetes, I'm so fed up of my obesity, I want to kill myself. Immediately refer. Patients with any kind of addictions, tobacco addiction, alcohol addiction, they have to be referred. And patients who are undergoing severe stressful situations. Many times, what the non-psychiatrist professionals feel is that if there has been a death in the family or a financial loss in the family and the patient is showing some kind of disturbed behavior, they explain to themselves that this is a normal response and they don't refer. They feel that only if the patient decompensates, we will refer. It's not like that. We have to refer the person so that the person gets support during their stressful situations and the outcome of mental illness or decompensation can be avoided. Now, the moderate requirement cases are patients who have a family history of schizophrenia, family history of bipolar disorder, family history of substance abuse. They may not need to go today, but sometime during your treatment, encourage them to see. Patients who are under active stress, which is going on for a long time. House has gone in redevelopment, house has not been delivered. Promotions has not happened, marital discord. Patients with disturbed biological functions, patients who are not sleeping well, eating well, after your diabetic or diet interventions, there is no return to normalcy, take an opinion. Less than expected response to your best treatment and difficult consultation behaviors. So, the type of patients whom you are not looking forward to see, try to encourage them very nicely. There may be some genuine kind of issue. And low probability is whether consultation experience is smooth, the response to treatment is as expected, and the risk factors for mental illness such as family history, substance abuse, or previous history of mental illness is not present. Now the big question that everybody asks me, कोणाला पाठवायचं, सायकॅट्रिस्टला पाठवायचं का सायकोलॉजिस्टला पाठवायचं? It's not that. Actually, there are such a huge list of mental health professionals. Counselors are people who talk to the patient, help them to express their emotions and educate the patient about a particular domain of their expertise. For example, diet counselors. After a diagnosis of diabetes, diet counselors are supposed to give emotional support, give dietary information and advice. The more advanced is also what you do, that you go into the total assessment. Or there could be counselors who are de-addiction counselors. So the specialty differs. Clinical psychologists are people typically who do the different tests. The intelligence test, the Rorschach test, personality tests. So if you want to get any tests done, send them to clinical psychologists. Therapists are people who actually treat mental illness. So people who will treat moderate cases of depression, who will treat OCD using specific therapeutic methods. Psychiatric social workers help to solve group problems, like there is a marital problem, there is a family problem, there is a workplace problem. They are experts in assessing and treating that. Occupational therapists use different kind of activities to help recovery of function of the patient. And finally, psychiatrists actually, they are believed, or many psychiatrists themselves believe that they know all this, but that is not true. Unless psychiatrists have formal training in therapy, they cannot do therapy. They can only function as much as counselors. The main strength of psychiatrists is that they are medical professionals, so they will be able to assess medical causes of mental illness, medical complications of mental illness in addition to treating mental illness. Neurologists are also mental health professionals because now neuropsychiatry is the thing that is coming up. So a lot of mental health problems related, for example, hallucinations which come up in Parkinson's disease, they are treated by neurologists. So a lot of mental health conditions are treated by neurologists, and speech and language pathologists, they help in the early stages for a lot of developmental disorders. They have a preventive role in preventing evolution of learning disabilities and those kind of things, and in older adults in the treatment of dementia. So this is a very simple pro forma that I have made, which you can put in your clinic. The instruments suggested, on the left side are the instruments which can be easily downloaded from the internet. The self-report questionnaire, it has 20 questions, and any 2 positive questions, you can say that the patient has some kind of mental illness which requires a referral. The general health questionnaire has different versions. There is a short form, there is a long form, and the scoring is given under that. It's again available freely on the internet. Prime MD is a very short questionnaire to rule out depression. Even one positivity indicates that the person is depressed and requires intervention. It is available in 12 Indian languages. Eating attitudes questionnaire is used to screen for eating disorders. 2 kinds of eating disorders are important in obesity. One is the bulimia nervosa, in which the patient is continuously preoccupied with food and they consume large quantities of food, which is followed by compensatory actions, like either they vomit or they use a lot of laxative to remove the food from their system. And second is the binge eating disorder, in which there are episodes in which they consume large quantities of food. So these 2 eating disorders do require formal psychiatric intervention. Now this is on the right side. I have made a small proforma which can be used in any clinic, like how we give some consent form and all. With that we can give this. We can have the name, age, sex, and according to your choice you can incorporate the SRQ, GHQ or Prime MD on the first page, which the patient can fill in your OPD outside in the waiting room. On the back side you can write current psychotropics, past history, substance abuse, family history, and then classify your patient as probability of high, moderate or low. Any positivity from SRQ, current psychotropic, past history, substance abuse or family history means they will come in high and moderate. And if they have rated negative for all the items, then it's a low probability for requirement of psychiatric referral. So this is my short presentation to you.
I'm your enemy between the lunch and. Okay, so I'll make it.
I have shared the presentation on the MBM this thing, so you don't have to take any photographs.
Okay. Can I have it here? Yeah, so I was told to speak on the behavioral management of obesity. Now, are you able to put it?
Yes, sir.
Yeah. Okay, so out of all the things that we've learned now is that yes, managing obesity initially is okay, but maintenance of that loss of weight is where the difficulty lies, and where the role of a therapist or your behavioral management of obesity comes in. So I'll not go into all this since we don't have time. So mainly cognitive behavior therapy and interpersonal therapy are the ones that show evidence in obesity. So here we have the goals of behavior therapy in this is going to be modifying and monitoring the food intake, modifying their physical activity that we have to do initially itself. This third one is very important, that is controlling cues and stimuli in the environment that trigger eating and overeating. Now, this is not alone in the stimuli, but your internal stimuli. So it's not alone the external stimuli that I'm talking about. So psychoeducation is something which is very important, and psychoeducation based cognitive behavior therapy is the main role in obesity that we talk about. Now this psychoeducation can be done individually, it can be done in a group-based therapy. I think group-based therapy would be okay because in a country like ours where we have enough of population to treat, I think all of them you can call up on one single day, 2 hours in a week. If you can give up your time, it will be cheaper option for the patient as well and more convenient for you all. The group should be a closed group. A closed group is one in which you don't incorporate new patients at that time. So you say that, okay, this is our group and we're going to take it forward for the next 8 weeks and we're not going to get any new patients into this group. So this helps in developing deeper awareness about the relationship between the triggers, thoughts, decisions and feelings. So these are the interventions that I'll be talking about, okay, one at a time. Self-monitoring. So this can be done, actually self-monitoring is just looking at the amount of food that I'm eating or the amount of exercises or the number of steps that I'm taking per day. Okay, so this can be done with a lot of apps that are available on your phone. It can be done even as a diary-based, as a journal-based system. Many obsessive patients actually like to write it down. So you give them the option of how they want to continue that monitoring, but this monitoring should be done. In a group, one advantage is that you can always share this monitoring details on a day-to-day basis so that a person who's less motivated can be more motivated to then further go ahead and join the rest in the group. In a group, we don't usually discuss the weight. Weight is something which is actually has that shaming context to it. So when we discuss that, my weight has come down by 2 kgs, it's okay to say that my weight has come down by 2 kgs. Never ask a person what are you weighing right now. Okay, so always keep that in mind when you're working in a group. So we can have these self-monitoring apps, smartphone apps, and this helps the person feel more responsible about food intake and exercise and then how to modify them later on. It also slows down your decision making process. So when you're self-monitoring, you're thinking that, okay, these are the number of calories I'm eating, and you're writing it down. So when your next meal comes up, you're actually watchful about it. You slow down your decision about having that, binging that meal next. And that is how, you delay that, and, you get over that craving for the food. Also, tracking weight is another application of self-monitoring that gives an objective feedback to your guide, whether you're eating right or you're not eating right, you're exercising or not. But at the same time, the person should not weigh themselves very often. It becomes detrimental then. Setting of objectives, this is the group leader. Okay, so whoever's taking up the group therapy should be doing it, in which you set objectives, that is, goals should be realistic and achievable. Now, a 110 kgs person comes and tells you that, I want to be weighing 80 kgs by the next month because my cousin is getting married. You know that the goal is not realistic. So keep them, very realistic and achievable. So, talk about 10% of weight loss in this much period of time, like whatever is encouraged by you. Tie other goals like lipid levels, your blood sugars, to the weight goals also. Or, probably, regular menstruation in a PCOS patient. This increases their motivation and adherence to treatment. One can designate daily calorie intake levels, exercise goals, and food intake goals. So, the group leader has to designate these goals, and every day, all the group members have to report back on the group. So these days your WhatsApp groups are very common. You can report back on those groups and see whether you're catching up with the rest of the group or not. And dividing any distant goal into a number of smaller goals. We all know that, instead of trying to achieve that, okay, I'm going to walk 10,000 steps in a single day today, when you've not walked for ages together, obviously you divide it and you say that today I'll do 3,000, tomorrow, I'll go up by 500 more, etc., etc. In stimulus control. So stimulus control is something that you're trying to control the environment which is actually making you binge or making you overeat. It could be the external stimulus, it could be your internal stimulus. External stimulus is something like, seeing a cookie jar when you come back home. You're actually fatigued. Inside your head, you know that you're not hungry. You're just feeling tired and fatigued after coming back home, but you see the cookie jar lying right over there and you want to have a cookie or a cold drink that's lying in your fridge. So this refers to rearrangement of the environment in regard to food stimuli. Just like in alcohol, no? We say, don't go and sit in bars with your friends. Even if you're going out for dinner or lunches, go to a place which doesn't serve alcohol. So the same thing applies in obesity, wherein it refers to the rearrangement of the environment. You don't keep these heavy calorigenic foods at home. Sight of snacks, as well as the knowledge of snacks being in the cupboard, might be tempting. Sometimes you tell them and to keep it inside and not go and take it, not go and eat it. Let that anxiety rise. Okay, let them feel, frustrated about not being able to eat it, and then see how they can resist it or not. External controls, not keeping high calorie food in the house, keeping fruits or other. So we can always tell them that you have cut salad or cut fruits or fruit salad lying inside the fridge. Just in case you're hungry, you grab that instead of anything else. Reminders to exercise on the bathroom mirror. So you get up in the morning, you have a sticky kept on your bathroom mirror telling you to go out and exercise. Keep your walking shoes next to your bed, or wherever you're going down to make a cup of coffee or tea for yourself, keep your walking shoes right over there with your socks and everything intact, so that you're tempted to go out and take a walk. The internal stimulus control are the ones that are difficult, and that we as mental health professionals actually manage a lot. That is in learning to deal with the emotions like sadness, happiness, loneliness, frustration, like Vaishali and Phadke sir were just talking about, you're seeking out for something, you're compensating it with food. So these are the emotions that we tell them how to deal with. And sometimes the craving itself, we give them the sea wave example, that when you're getting a craving to eat something which is highly calorigenic, think you're riding a wave, you're going up the wave, the craving is increasing, but ultimately it has to crash down. So just let go, just postpone it for a while, and the craving also goes away. Then we teach them problem solving skills. So they are encouraged to consider different solutions before selecting the healthiest options, especially in places when they have to go out and eat, or they're going on a holiday, they're going along with friends, how to say no. That saying no, being assertive, is very important for them. Social eating and eating outside of home, we ask them to generate what kind of solutions do they have. So in a huge group, you'll actually come up with multiple solutions. So, you can fit in what is best for yourself and implement that particular solution for yourself. So that's like a problem solving approach in this group. Emotional eating also, we tell them to find out solutions to this emotional eating, and people learn from each other in the group. And one shoe may not fit all, so we have to keep trying. Problem solving doesn't actually mean that you find a solution to a problem and that solution is the best solution. So tell them to fall down, it's okay, but then get up again, seek for other solutions and keep going, keep going, keep going. Positive reinforcement, just like we tell a child that if you clean this up, the mess that you've created, I'll give you a chocolate. The same thing applies to this particular person who's doing their regular exercises or limiting their food intake. So in them, obviously you can't give them a chocolate or you're treating them for obesity. Also they're grown-ups. So you have to find out other things for positive reinforcement in them. So healthy eating and exercises, they can be supported with conscious application of positive self-talks. Even a kind of a positive reappraisal that the group therapist, the leader gives, or the group members give to each other, that itself is good enough for a person to go ahead and continue with the same behavior later on. People who struggle with their weight tend to be harsh, very harsh on themselves. They have a very low self-esteem. They consider themselves to be very inferior to others. So they already have a very low self-esteem and they are harsh on themselves. So asking them to do these positive self-talks like, I'm getting there, or, I'm getting better, I'm doing what I've been told to do, praise themselves often itself is a positive reinforcement for them. Cognitive restructuring is something which I don't want to preach away, but that is something that we all do as therapists, as cognitive behavior therapists, in which we see, certain kind of cognitive patterns in these patients. They have these perfectionist standards in which they say that, I must be thin, that, mustitation, that I must be thin. It's not like that, I wish to be thin, it is, I must be thin. Unhelpful rules like, I can't waste food. So, we've been taught in cultures that no food should be left on the plate. Please, let go, it's okay. So, all or none thinking, like, either I'm completely on my diet, or even if I have an extra cookie, that means I'm off my diet, I'm not good enough. So that's that all or none thinking. Exaggerated thinking that, I can't stand this craving at all. Oh my God, I've been told not to eat for this long and I can't stand it at all. So all this we do in cognitive restructuring. Most of the people who want to lose weight, often they count their calories, they think about their weight and about the food that they can't have. So they keep having these monologues inside their mind. During the phase of cognitive restructuring, we help them, help the patients to question these monologues and to deal with them as well. Patient is encouraged to identify the thinking that inevitably contributes to diet failure and build skills to motivate themselves to resist temptations. Like I was talking in the morning about the lapses, not turning into relapses is very important. So it's okay, one day they fail, they have, they overeat on a holiday, it's okay to come back and then restart. So you as a doctor, as a clinician should not be warning them, look, you should never fail in this. Okay, I'm putting in so much of effort, you should be put in your effort. You should have them, coming back to you with welcoming arms. Let them know that, whatever goes wrong, I'm there for you. So they'll always come back to you. So that lapse turning into a relapse will be less of a chance. I can't say all the time, but less of a chance. Their diet and food plan, different studies have suggested that people with obesity lack a healthy cycle of eating. So they go either into binge eating or the dieting, overeating cycle. So they'll have a diet phase for a month and then overeating again. And periods of disinhibited eating. So together, like they'll not eat at all for a week and then again they'll go and overeat along with that. They eat specific foods, just teaching them to eat specific kind of food at a specific time and specified places. Okay, not eating anything, anywhere and anytime is important for them. Make the act of eating a singular event. So you're not allowing them to eat with the TV on, with their screens on, or with a book in hand, or while talking on the phone. So make it a singular event, which is important for their diet and food plan. Learning to say no is an essential part of losing weight. So Teach them assertiveness, so that they can say no to those friends who are trying to force them to eat food when they've gone out together or on a holiday. Most of the time it's not the other way, it's our own craving which makes us eat. But anyway, if they feel sorry about saying no to a friend, I think teaching them assertiveness is also important over here. Doing regular exercise is important. This again, it can be put down on a diary, in a journal, or on an app, and it can be monitored by a person. Body awareness, mindfulness, and relaxation are very important components of obesity. Okay, your eating, hunger, fullness, craving are all sensations that can only be experienced. They're very subjective. You cannot have an objective point of view about it. Okay, so even if you have a scale to it, it will be a very subjective scale. That how hungry are you on a scale of 0 to 10? There's nothing else, a lab value that can tell you how hungry you are. So the only way to experience those sensations is to connect with your own body and to become more aware of what is happening in a mindful way. Patient is expected to slow down the eating and to make eating a pure experience, unaccompanied by any other activity, like I said. Also, relaxation helps these individuals to deal with their stress and negative emotions. Now, regarding mindfulness, I'll just take a few moments of yours before your lunch. Let your body catch up with your brain. So eating rapidly, fast, full, and ignoring your body's signals versus slowing down and eating and stopping when your body says that you're full. Okay, so that's very important, to let your body catch up with your signals. Know your body's personal hunger signals. Okay, so know whether you're responding to actually an emotional need or actually a hunger pang. Be careful about that. So just because you're bored or you don't have anything else to do, don't go and grab something to eat. Develop healthy eating environments, eating alone and randomly versus eating with others at set times and places. So sitting on a dining table, eating with your family would be preferred rather than sitting and eating alone. Consider the life cycle of your food, from how it was grown and how it has come with the presentation on your plate. That will all, just slow down the eating process, that's all. Attend to your plate. It is like, don't have a distracted eating pattern or just eating for the sake of it, but, attend to your plate, look at it, admire it, feel all the sensations and then go ahead and eat. So, Pankasa, will you take their mindfulness a little bit or should I finish it off and then?
Finish it, you finish
Finish
it.
it off because
Please.
it's time for lunch.
Yeah,
So there's a lot about emotional eating because binge eating and in bulimia nervosa generally we see this kind of pattern of eating. This refers to turning to food to compensate the unmet negative emotions like anger, loneliness, boredom, and the person should pay attention to when he is hungry so that they can respond properly to their primary needs. Just go. So this is a behavior diary that we ask patients to maintain. Okay, so this is the date, time. First column, the situation. So for example, they write down that, being alone or boredom was the situation. The thought was that, I'm alone, no one likes me. How did I react? I ate a box of cookies. How long did the feeling last? For about 30 minutes or so. How did I feel after that? I felt more sad and more angry. How could I have reacted better? By taking a walk, hobby, talk to someone. So this is a kind of a diary that we ask a patient to maintain. How it helps out is, they present this diary in front of the entire group. They are given ideas for this last column. How could you have reacted better? And also, this feeling needs to be addressed by the therapist or a mental health professional, or, the underlying cognition, the thought itself needs to be dealt with by the mental health professional. So this is a behavior diary that we ask patients to maintain. Then there are some things like body avoiding behaviors in which people who are very obese, they try to avoid situations like, facing the mirror because there they feel that their body is being scrutinized, they start wearing oversized clothes. How it can be modified? By graded mirror and video exposure. So they ask them to actually go and start standing in front of the mirror for a few minutes and keep observing their bodies. Behavioral experiments like, wearing a size little less than what they're trying to wear, the oversized clothes, and then tell them to go out in the society or meet up with friends. So these are the behavioral experiments that we ask them to go undertake. Then there's a body checking behavior. These are repeated behaviors aimed at checking one's weight and shape. So the other one was avoiding. This is the other extreme of repeatedly checking. So these patients, they weigh themselves repeatedly or they keep seeing themselves in mirror repeatedly. How do we modify it? By exposure response prevention. So we expose them. We tell them that, you don't have to, you go to the weighing machine but don't have to step on it. Or even if you see the mirror, you don't have to go look into it, or you put a curtain, or you see yourself only once in like say 6 hours in the mirror or something like that. So this is how we restrict the body checking behavior in these patients. The relapse prevention, I'll not go into it because I just spoke about it in your motivation enhancement. So I'll leave these slides because this is a very good psychoeducation program, CPT based by a person called Judith Beck. She's a proponent of CPT, and she's given this 8-week long group psychotherapy program. And these are slides which I will leave behind. Vishali, you can share with all of these people. One thing is there that these people also they use a buddy system in which generally they gather support from each other also, and they can report back if they're feeling low, lonely, bored. They get back to the person, their buddy, and they get some kind of support from each other as well. So tips to follow in your daily life is use your senses, which is very important. The mindfulness, mindfully serve your food, become aware of your portion size. Chew slowly so that your brain starts responding to your stomach. Reduce multitasking, so concentrate only on your eating when you're doing it. Avoid being too hungry before ordering food. You'll always land up over ordering your food. Or even buying food in food stores. You'll always grab something which is very calorigenic when you're going hungry and purchasing things in a store. Break the habit of clearing your plate. It's okay to waste food. It's fine. Especially mothers, who see wasting food, when kids wasting their food, they always tend to overeat. Use compassionate language towards yourself. Like I said, usually people who are obese are very harsh to themselves. So use compassionate language saying that, I failed today, but it's okay. I'll recover tomorrow again. Be realistic and moderate in diet and exercise. Don't overdo anything because you'll not be able to maintain it. Remember that maintenance is more important than the acute treatment in this. Accept yourself and your body. Sometimes we have these patients who don't lose weight in spite of putting in all efforts. I think you should just tell them to be happy with their body and continue doing the lifestyle changes which will ultimately keep them healthy. Maybe not, losing too much of weight, but at least healthy. Don't use mirror to judge yourself. Have a mindful response to cravings also. So I'm hungry. Can I be more mindful about what I want to eat? Socialize without food, like we were discussing yesterday. Do not skip meals. If you have a pattern of 3 meals in a day, have it thrice a day. If you have 2, then have it twice a day. Do not confuse fatigue with hunger. I was just mentioning, most of the time we come back from work, we're saying, we're not hungry, but we're feeling fatigued and tired and we just want to eat. Practice gratitude for food that you eat. You'll not overeat then. You'll always consider how it came and the kind of problems that the food has undergone. So these are the BK. Okay. In bulimia nervosa and binge eating disorder. So many of your obese patients will be having this binge eating disorder, and rectification of these disorders, these underlying disorders, is very important if we want to deal with obesity in these patients. So we have to deal with body image disturbance. This again is a talk in itself. Reducing their impulsivity. Okay, obesity is very closely linked to ADHD, that is attention deficit hyperactivity disorder, and bulimia and binge eating disorder also come along with obesity. They are all interlinked disorders. So reducing their impulsivity itself will reduce their binging. Reducing emotional eating. So identify your emotions, deal with your emotions rather than going and picking up something to eat. Behavioral weight loss and exposure response prevention in these people as well. What can clinicians do with these patients? Reduce stigma. It is a health issue. Talk to patients about their current health status and goals. Like, talk as in their weight, their lab values and all that. Avoid terms like fat, heavy, large size, things like that. Talk more, in medical jargon over here. Say BMI, say your weight is this much, you're overweight by these many kilos. But avoid these kind of terms which have a negative connotation. Educate the clinic staff also about not making overweight individuals feel embarrassed. That's a very important thing, Many times they turn up at the clinic and they're ashamed. Family counseling, like no TV while eating, exercising together, probably that increases your chance of exercising. Reducing their criticism. Will criticism ever reduce anyone's weight? Especially adolescents. Okay, you try criticizing them and see what happens. They're just going to do the opposite. Address family views on weight. So again, if there's too much of criticism, hostility about the obese person, then address their views on weight. The psychiatric medicines and other medicines that I won't get into. How do we prevent it? Okay, we've been talking a lot about obesity. I mean, what do we do to help the next generation, at least, from the mental health point of view, to start controlling obesity? All these things should be delivered in groups in schools and colleges, because this is like a population which is about to grow, and they are the kind of people who go and eat junk food, getting into obesity in their formative years. Education of this population is very important. Focus on modifiable risk factors. I'm again pertaining to only the mental health issues, like appearance pressures in environment. The social media, it has a big role. So, you have to address that, because these children, they develop a lot of body image disturbance at this young age, looking at all the social media things. Be assertive in case of body shaming. So an obese child who's being body shamed by others should be taught assertiveness about, telling the others that, I don't like being body shamed, because this child will again get into its own cocoon and then land up with depression, or, maybe the obesity also will go up. Avoid upward appearance comparisons, the size 0 of Kareena Kapoor, etc. Make them more realistic in life. Build skills to analyze and evaluate the media, especially the social media literacy that these days they have. So ultimately, I said to my body softly, I want to be your friend. So treat your own body as a friend. Okay, don't think that, okay, this weight is excessive and I don't like it and things like that. So treat your body as a friend. It took a long breath and replied, the body replied, I have been waiting my whole life for this. Thank you.
Thank you, Arti. Now I understand why Mama is psychiatrist and psychologist, because I probably wanted this kind of an explanation someday. But nevertheless, I think there is a lot of psychology to treatment of obesity. That's what I got to know from Arti. And just 5 minutes before we break for lunch, I would like to felicitate all our esteemed faculty, because they have done a wonderful job. A big round of applause for everyone. So I would like to hand over to Paula to help me with the felicitation. So beginning with Dr. Sanjay Phadke sir, the chief.
Why you want me to felicitate here? I am part of organizing this one,
So it's our duty on behalf of SPHERE, and can I request Dr. Chetan Deshmukh to come over and felicitate? Dr. Vani. because I think we are doing this. We missed you for first 3 days, but definitely I look forward to you. So post-lunch we'll be hearing him, and I think it is a talk not to be so sorry, just Dr. Namrata Gadbade. Thank you so much for the star of the show. We have our participation of all our farmer sponsors. I think it wouldn't have been possible without their support to have some program of this magnitude and this quality. So I would request the farmer, if there are any, I would welcome. This guy, okay. So Mr. Venugopal from Boringar, Ingelheim, actually been a strong support from the background. Dr. Ambekar sir, please, and Dr. Marwade sir. Dr. Marwade sir is not here, but I think you can. Dr. Padke sir can take on his. Oh, we are the host sir. So this is for Dr. Marwade sir. Ambekar sir. So, Dr. Marwai sir, wherever you are, this is for you.
Gets all the MMC points and all that. So
I know he has been working silently for all of us. So, to thank our pharma partners, and I would welcome Mr. Dr. Chetan Deshmukh to felicitate.
वैशाली देशमुख sir.
Oh God.
Farmer.
Boringar sir. So, Boringar Ingelheim, Mr. Venugopal.
आलाय का वेणुगोपाल आलाय.
Yes.
अरे आता बोरिंगर तो आपण चर्चा केली.
So, they have been very supportive. They have been here for past 4 days and been very active participation.
We discussed your MPA great deal.
Then we have, you're from Dadleon, right? Thank you for the generous support. We hope that we get this support in future also.
Good.
Lupin Metabolics. You have anybody from Lupin Metabolics? No? Okay, so I think Chetan can take it on their team.
Yes.
Then Lupin Diabetes Care. Anybody from Lupin Diabetes Care? Then MCure Pharmaceuticals. Anybody from MCure? Nobody?
Lunch लागेल.
Lunch level. So, okay then. Biocon. Sadan, you can come. Thank you, Biocon. And come. Yes, please come.
Wait.
Whom have I missed? You all are all from the same team? Okay. So, Intas Pharmaceutical? Yes, please. And anybody from Celogenex today? We had Mr. Omkar from Celogenex yesterday, but I think today we don't have them. But nevertheless, we thank all our sponsors who are here and who are not here. And we hope that we have new sponsors, new funders, new partners into our segment of mind body medicine, because as you all see that mind body medicine is an integral part of NCD management. Yes, sir?
वैशाली मैडम को देने का है ना यार. शिवराम सर आजा.
My brother has done a very silent and a good job. I think I should just a round of applause for the silent workers. He and my husband, Dr. Chetan Deshmukh, has been my backbone, and they have been the ones who have always been my support. And I thank both of them.
यार निमॅन्स आणि एम्स कडनं घेऊ दे. तुम्ही आज कम घ्या बाबा. वैशाली मॅडम
Dr. Patwardhan sir has been a strong support for mind body medicine, and he has been the backbone of the Endocrine Society.
Ma'am, look here.
So it has been very kind support of his that we could do this in the endocrine fraternity. So thank you, Patwardhan sir.
हेडिंग तो पढ़ लीजिए.
Wonderful, yeah.
अच्छा, be employed नहीं, sorry, be empowered. I thought he's giving me a good book, be employed.
Poetry, one of the PhD student and translated it was in Punjabi. So this is
Wait.